Figure 1.3. Normal distribution and reference range. For many tests, the frequency distribution of results in the normal healthy population, red line, is a symmetrical bell-shaped curve. This means plus minus 2 standard deviation SD encompasses 95% of normal population and usually defines the reference range. 2.5% of the normal population have values above and 2.5% below this range shaded areas. For some diseases, blue line, test results overlap with the normal population or even with the reference range. For other diseases, green line, test may be more reliable because there is no overlap between the normal and abnormal population. The critical difference. The critical difference is different for each test and can be high, 17% in the case of cholesterol and higher for some other tests. Factors other than disease that influence test results. A number of factors other than disease influence test results: age, ethnicity, pregnancy, sex, spurious in vitro results. Box number 3 gives some examples. Operating characteristics. Tests are also subject to operating characteristics. This refers to the way the test is performed. Patients need to be able to comply fully with some tests, such as spirometry, and if they cannot, the test result will be affected. Some tests are very dependent on the skill of the operator and are also affected by the patient's body habitus and clinical state. Ultrasound of the heart and abdomen are example. A common mistake is when doctors refer to a test result as no abnormality detected, when in fact the report describes a technically difficult and incomplete scan that should more accurately be described as non-diagnostic. Some conditions are paroxysmal. For example, around half of patients with epilepsy have a normal standard electroencephalogram EEG. A normal EEG therefore does not exclude epilepsy. On the other hand, around 10% of patients who do not have epilepsy have epileptiform discharges on their EEG. This is referred to as an incidental finding. Incidental findings are common in medicine and are increasing in incidence with greater availability of more sensitive tests. Test results should always be interpreted in the light of the patient's history and physical examination. Sensitivity and specificity. Diagnostic tests have characteristics termed sensitivity and specificity. Sensitivity is the ability to detect true positives. Specificity is the ability to detect true negatives. Even a very good test with 95% sensitivity will miss 1 in 20 people with the disease. Every test therefore generates false positives and false negatives. Examples of factors other than disease that influence test results. Age. Creatinine is lower in old age due to relatively lower muscle mass. An older person can have a significantly reduced eGFR with a normal creatinine. Ethnicity. Healthy people of African ancestry have lower white cell counts. Pregnancy. Several tests are affected by late pregnancy due to the effects of a growing fetus, including reduced urea and creatinine, hemodilution, iron deficiency anemia, increased demand, increased alkaline phosphatase produced by the placenta, breast D dimer, physiological changes in the coagulation system, mild respiratory alkalosis, physiological maternal hyperventilation, ECG changes, tachycardia, left axis deviation. Sex. Males and females have different reference ranges for many tests. Example, hemoglobin. Spurious in vitro result. A spurious high potassium is seen in hemolysis and in thrombocytosis. Pseudo hyperkalemia. ECG, electrocardiogram, EGFR, estimated glomerular filtration rate, a better estimate of renal function than creatinine. A very sensitive test will detect most disease but may generate abnormal findings in healthy people. A negative result will therefore reliably exclude disease, but a positive result does not mean the disease is present. It means further evaluation is required. On the other hand, a very specific test may miss significant pathology but is likely to establish the diagnosis beyond doubt when the result is positive. All tests differ in their sensitivity and specificity, and clinicians require a working knowledge of the tests they use in order to accurately interpret them. In choosing how a test is used to guide decision making, there is a trade off between sensitivity versus specificity. For example, defining an exercise electrocardiogram as abnormal if there is at least zero point 0.5 millimeter of ST depression would ensure that very few cases of coronary artery disease are missed, but would generate many false positive results, high sensitivity, low specificity. On the other hand, a cutoff point of 2 millimeter of ST depression would detect most cases of important coronary artery disease with far fewer false positives. This trade-off is calculated using the receiver operating characteristics curve of the test. An extremely important concept in clinical decision making is this: the probability that a person has a disease depends on the pretest probability and the sensitivity and specificity of the test. For example, imagine an older woman has fallen and hurt her left hip. On examination, the hip is extremely painful to move and she cannot stand. However, her hip x-rays are normal. Does she have a fracture? The sensitivity of plain x-rays of the hip performed in the emergency department for suspected hip fracture is around 95%. A small percentage of fractures are therefore missed. If our patient has or is at risk of osteoporosis, has severe pain on hip movement and cannot bear weight of the on the affected side, then the clinical probability of hip fracture is high. If, on the other hand, she is unlikely to have osteoporosis, has no pain on